Hello guys, it's your dream doctor here. Today I'm going to discuss a new topic which is leukoplakia. What do you mean by leukoplakia? According to WHO, leukoplakia is a white flag of questionable risk having excluded known diseases or disorders that carry no increased risk for cancer. So എന്തത് ലുക്കോപ്ലേക്കിയ എന്ന് പറയുന്നത് ഒരു വൈറ്റ് ഫ്ലാഗ് ആണ് വിച്ച് ഹാസ് ഹാവിങ് എ ക്വസ്റ്റ്യനബിൾ റിസ്ക്. പക്ഷെ നമുക്കറിയാവുന്ന എല്ലാ ഡിസീസസിനും നമുക്ക് എക്സ്ക്ലൂഡ് ചെയ്യാൻ പറ്റുകയും ചെയ്യണം. ഓക്കെ, അതാണ് ലുക്കോപ്ലേക്കിയൻ്റെ ഡെഫിനിഷൻ അക്കോർഡിംഗ് ടു WHO. Or we can say that leukoplekia is a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable lesion. It says leuko means white, plakia means patches, which is non-scrapable in nature. So it's a predominant white patch or plaque of the oral mucosa. It's one point, and it cannot be scraped and cannot be clinically or histopathologically characterized as any other diseases, and most common potentially malignant disease or disorder, and risk of malignant transformation into oral squamous cell carcinoma is high. Okay, then leukoplakia is commonly seen in buccal mucosa, tongue, floor of mouth, oral alveolar mucosa, etc. Malignant transformation rate of leukoplakia ranges from 1% to 20%. Now moving on to the etiology of the oral leukoplakia. Main thing is the tobacco usage, then chronic trauma or sharp teeth, alcohol consumption, fungal infection, nutritional deficiencies, denture irritations or idiopathic factors, and viral infection. In viral infection, the main thing is that HPV virus. Okay. In the etiological factors, tobacco can be smoking type. Tobacco can be smoking type, that is cigarettes, BDS, etc. and smoke less like gudka, pan masala, etc. Then other factors are UV light, mainly seen in vermilion borders and candidal infection, HPV 16 and 18 virus, then genetic factors and UV radiation. Clinical features of leukoplakia. It's a white patch, and the main thing is that the burning sensation and which is non-scrapable. The clinical variants are non-homogeneous variant, which is there is only presence of white patches, and non-homogeneous, which means there is both white and red lesions, and there is ulcerative lesions. In leukoplakia there is regions where is ulceration take place or erosion is seen. Then this is a normal lip, and these are the lips with leukoplakic lesions. The ages which show leukoplakic lesion are the middle age or very elderly people, which is 50 years plus, and there is a male predilection, and these are the other variants like erythroleukoplakia. What do you mean by erythroleukoplakia? Erythro means red, leukoplakia means white patches which is non-scrapable. So it is white and red patches, that is erythroleukoplakia. Then this is atrophic or inflamed tongue, and this is a homogeneous white patch lesion, and this is a leukoplakia with ulceration seen, and this is the indication of burning sensation, and this is the lesion present on the floor of the mouth. Moving on to the histopathological features. There are several main important features like hyperkeratosis, which means there is an increase in deposition of keratin, thick keratin layer, as you can see over here. Then there is elongation of rete ridges, means these rete ridges get elongated. See, you can see that, and it become drop shaped or it's broadened. Okay. Then see the basement membrane. This basement membrane is intact. There is no split of the basement membrane. It is completely intact. And you can see dysplastic features, or they are dysplasia. Epithelial dysplasia is showing that there are certain features which is called dysplastic features. Some features are loss of polarity of the basal cell layer. Then there is increase in the baseloid appearance. There is more number of layers which appears near the basement layer or the basal layer. That is, the more layers of basaloid appearance. There is increase in nucleus and cytoplasmic ratio. There is drop shaped retipex. Irregular epithelial stratification is seen, and increased mitotic figures, nuclear hyperchromatism, reduced cellular adhesion. See, there is reduction in the cell adhesion. There is hyperchromatic nucleus and enlarged nucleolus is seen. Then mitotic figure, can you appreciate this mitotic figure? And these all are the dysplastic features. And see the connective tissue, there is our inflammatory cells infiltration. This is the histopathological features of oral leukoplakia. This is also the diagram showing the histopathology of leukoplakia. Here you can appreciate the hyperkeratinization. Then see the dysplastic features. Dysplastic features including architectural changes and cellular changes. In architectural changes, there is loss of polarity, disoriented maturation from basal cell to the surface layer. Then includes top to bottom changes, and there is increase in cellular density is seen. Then the basal cell hyperplasia, which means there is increased number of basal cells. Then dyskeratosis, bulbous and drop shaped retipex are seen. There may be secondary extensions on the retate tips. These are the architectural changes occurring in dysplastic features. Then there are cellular changes. What are the cellular changes? There is nuclear pleomorphism. What do you mean by nuclear pleomorphism? Which means there is different, morphologically different variants of the nucleus. Means the nucleus is showing different shape or size or etc. It's pleomorphism. Then cellular pleomorphism, like the cell is also showing different size or shape or something. So it's cellular pleomorphism. Then there is an increase in nuclear cytoplasmic ratio. What it means? Comparing, when we compare the cytoplasm and the nucleus, the size of the nucleus increases as compared to the cytoplasm. So hence it's there is increase in nuclear cytoplasmic ratio. Then enlarged nucleoli and the cells, there is nuclear hyperchromatism. The chromatin pigmentation is higher, and there is increased mitosis. So we can appreciate the mitotic figures. Then abnormal mitosis, there is increase in number and size of the nucleoli. These are the features, dysplastic features. Then the other features are there will be change in keratinization. There may be deposition of parakeratin or orthokeratin. Okay, then epithelial dysplasia, and the epithelium shows thickness. The thickness of the epithelium will increase. Then in the connective tissue, there may be aggregation of inflammatory cells. These all are the changes we can appreciate from a histopathological figure of leukoplakia. I hope you understood. Okay, this is the staging of the leukoplakia by van der Waals 2000. Okay, the first stage is where the lesion is less than 2 cm and there is no dysplastic feature is seen. So we can categorize it into stage 1, that is L1 P0 is the first stage. Then the second stage is L2 P0. L2 means the lesion is in between 2 to 4 centimeters and there is no dysplastic features. Then coming to the stage 3, it can be L3 and P0, which means the lesion is more than 4 centimeter and P0 means there is no dysplastic features. Or it can be L1 or L2 P1, which means small or medium sized lesion, that is it can be less than 2 centimeter or the lesion with 2 to 4 centimeter range with there is dysplasia or dysplastic feature is seen. And this is the fourth stage which is L3. The lesion is more than 4 centimeter and with P1, which means there is dysplasia. So let's revise once again. The first stage it's L1P0, the second stage it is L2P0, and for third stage it is L3P0 or L1L2P1. Okay, then the fourth stage is L3P1. Now moving on to the management of oral leukoplakia. When we diagnose the oral leukoplakia, first thing is that we have to eliminate all the risk factors, and we should regulate follow up and monitoring. And on examination, based on the dysplasia, we can divide it into no or mild dysplasia and moderate or severe dysplasia. In case of there is mild or no dysplasia, only thing we have to do is regular monitoring and topical agents like retinoids. And if there is a severe or moderate dysplasia, we will go for surgical excision of the lesion or laser treatment or cryotherapy. If it's a moderate or severe dysplasia, we should give long-term surveillance and patient education. Thanks for watching. Please like, comment and share.